second aspect of reducing pressure injury in critical care is reducing the duration of pressure against the skin and soft tissue. I don't have a lot to offer you here, but turning, and we know that we should be turning our patients. We sort of have a knowing doing gap, don't we? We know that we should turn the patients, but we don't turn the patients. And I want to explore that. There's evidence, I'm sure you've seen the evidence, that turning patients in critical care reduces their risk of pressure injury. Well, yep, could have guessed that, right? So how do we bridge this gap? Where are we falling down? Well, I think one of the things that you need to do is make sure the patient's ready to be moved. Are they stable? Have you tried small movements? Have you tried microshifting, just lifting one hip up, lifting one leg up, moving one shoulder? And is that being tolerated by the patient? Or are you seeing, pretty dramatic changes in rhythms or vital signs? Be sure you turn them slowly. Nobody moves quickly when they've been unconscious for a long time. You know that. Do use caution when you turn that patient onto their left lateral side. The left side is associated with a bit more cardiac dysrhythmia problems because of the movement of the heart in the chest. Leave them alone with enough time to accommodate to the position change. Don't immediately turn them back. And I think that's an important piece because we tend to jump on it pretty early. One thing you do see every once in a while are orders not to turn patients written by surgeons, written by other docs. I want you to treat that like a restraint. If a patient has an order not to turn, that's not a good thing. I don't know how you do your care. I don't know how you clean up incontinence if you have a patient who has a do not turn order. And if you're telling me, secretly, that even in patients with do not turn orders, you're moving them some to change the sheets, well, then you can move them. So think that one through. What we've seen in the academic world is that at the end of the rotation for the service, the surgeon or the surgery resident writes an order, do not turn, and then the next team comes on, didn't know that order was still written. So we have it verified every 24 hours that it's still in place. Certainly a benefit of reducing sedation. We've seen a reduced number of sacral and heel ulcers in patients who are not sedated. So start lifting that sedation as soon as you can. Really the story here is move them somehow, move them a little bit. You've got to keep that patient moving. They should not be perfectly still in your bed. So when ECMO is used, is that a situation in which the patient cannot be turned? And therefore, does that create what you might call an unavoidable, unpreventable, permissible pressure injury? Well, I'm going to challenge you on that a little bit. I want you to think about ECMO as a deterrent to fast moving. I want you to think about ECMO as perhaps creating situations where patients need a little bit more work to get them turned, but they still should be turned. So I want to introduce you to a study that was done where it was a hospital that was looking at very high rates of pressure injury in their patients on ECMO. Up as high as 65% of patients were getting pressure injuries. And what they did is developed a process and a team, including a perfusionist, trained ICU nurses, to move the patients. And they cut the rates down by 2/3, which is amazing. So they've kept the process going. They're using dressings to pad the patient, interviewing or intervening with the WOCN, the wound nurse, to make sure that he doesn't have any ideas, making sure the bed's an appropriate bed for the patient. All of that was done in an effort to reduce rates, and it worked. Well, there's a phrase that I know you've heard if you're in the critical care unit, and the phrase is hemodynamic instability. And it gets used a lot, and it gets used to try to explain a patient who is unsafe to be turned and therefore is not turned, and pressure injuries develop. Well, I'm going to do a shout out here to Kathleen Vollman and get Kathleen's take on this. Is hemodynamic instability simply a thing that we cannot change, Kathleen?
Joyce, that is a great question. So the answers really came from my own experience as well as the literature. So I started critical care nursing. I started nursing in the early 80s, and I was in a unit. It was an urban medical intensive care unit. They had the nickname Levifed, Leave 'em Dead, for the norepinephrine vasopressor. The patients were very sick, all ventilated, a significant number of ARDS, and we turned people every 2 hours. The only time I remember patients not being turned is when they were cardiac arresting or when they were being bathed. And so then I left there and I went to a number of different units, same type though, urban, teaching, medical ICU. I did do some trauma and similar thing. Same type of patient, vasopressor, mechanically ventilated, and it's also important to note that 12-hour shifts came on board during this time. And you may have not met me, but I'm fairly tall. So at about the 10th hour in a nurse's shift, I'd get flagged over to help turn the patient so they could change the sheets, so the patient wouldn't be messy and they wouldn't get yelled at and report. And so what do you think happened when we turned the patient? They crumped. Blood pressure went down, heart rate went up, SAT went down, and what do you think the nurse said in report? This patient's too hemodynamically unstable for turning. And so guess what? They spent the next 10 hours flat on their back until it was time to change the sheets again, and the same thing happened. And I said to myself, why did it work over here? And why isn't it working here? And the only thing that I could identify as different was the fact that we were routinely turning these patients. So maybe we were training them, getting used to it. And so during this time, I thought, I was reading research on what created that intolerance, and some of it was on the stretch receptors and changes in gravity. And I said, who knows the most about that? Exactly, Nassau. So I called Houston. I said, Houston, we have a problem. No, only kidding. I didn't say that, but I did call Houston, and I asked to speak to a medical expert, and I shared my theory with him. Actually, it's called prolonged gravitational equilibrium. And the medical scientist said, that makes sense because we actually train the astronauts' stretch receptors to tolerate zero gravity. We start at a half a G, then a full G before we shoot them up in a rocket. So they go through that training to tolerate it. And I went, wow. That, so that bells went off. And so it's possible to train patients to tolerate turning. How do we change the culture that is in our units? And part of that comes from several steps, and I've published on this and created a decision tree algorithm. The first thing is we have science that says the act of turning creates instability. So patients need 5 to 10 minutes to equilibrate to a position change. So what I tell nurses is take the SAT monitor off during the turn. No, only kidding. But what I do tell them is close their eyes, turn around, do whatever they need to do to prevent themselves from turning the patient back, because we really stop a lot of forward progression of mobility for the patient because of inappropriate evaluation of whether they are truly intolerant or not. The second thing is focusing on how we do the turn. Additional data out of the aeronautical research shows that there is a connection between inner ear equilibrium and the influence that has on cardiovascular response. And if you think about how we routinely turn patients, do we turn them soft and slow like this? No, it is a huge change in gravitational equilibrium. And so slowing down our turn is an important component. The third is spacing activities so that we are not doing 9 million things before we finally turn the patient without giving them any respite period, because they don't have the oxygen supply to meet the demand we're placing on them during a turn. So spacing that activity. And the last is really taking the opportunity to train the hemodynamically unstable patient by either rotational therapy and training them to tolerate turning, or it can also be done with wedges and incremental degree increase in microturns. And so there is a way to change the culture in your unit about hemodynamic instability with turning.
A lot of patients today are on progressive mobility programs, and that's great. I love it that we're moving people, but unfortunately what we're doing is sometimes moving them to the chair for hours on end. And there are orders written that say up in the chair as tolerated. And I don't know whose tolerance they're talking about. Maybe it's the patient, maybe it's me, because I'm not gonna tolerate looking at that patient anymore because they're about to land on the floor. So we put them up, and there's this thought that sitting up in the chair is good for you. You know, the longer you sit up, the better off you are. I'm not sure that's a true statement. Patients that sometimes are up in the chair have had thoracic or cardiac surgery. They can't use their arms to lift them up in the chair, so they just slide down in the chair. So then we elevate their feet, so we keep them from sliding down. And now to me, they look just like the patient in the bed in semi-Fowler's position, except the chair's got terrible padding. We don't have chairs that have good immersion and envelopment. So we increase the risk of pressure injuries in these chair-bound patients. So what's the approach here? What should we be doing with these patients? So what do we do for patients who have orders for progressive mobility and are up in the chair for a long time? Important to be up. Sitting up helps ventilation, helps oxygenation, and I'm in favor of that. But we need to recognize the chair is almost an accomplice here, you know, to the crime of pressure injury prevention. So check your hospital bedside chairs out. Are they good? Could you sit in one for 2 hours, or would you be sore? If your chairs don't have a good cushion in them, get a chair cushion for the patient. And really all you need is one with air cells. You don't need a sophisticated one. I would encourage you not to get the foam ones if your patients are incontinent, because you can't clean them. So there are 2 on the market at an elementary level. One is foam, one is air cells. So think about, you know, is this patient going to need it for a long time? Then you're better with the air cell one, because it can be cleaned and a little easier to maintain. Limit the amount of time they spend sitting, though. Patients should not be sitting without being repositioned for any more than an hour. And this is a patient who's conscious, and so you think they may be able to be making some movements themselves. One of the best ways, I think, to reposition patients in a chair is have them stand up, march in place, and then sit back down. What are we used to? We're used to coming behind them and yanking them back up to a seated position, which creates a lot of shear on their buttocks and, of course, a lot of stress and strain on us to do that.